All right, today we're going to cover this morning skin conditions. So the nice thing about this, since this is just around breakfast time, is there's no pictures. So usually when you hear you're going to be teaching a program on skin, people are like, oh, over lunch? And I'm like, yes. Okay, so let's start off. And what we have here, let's see if I can get this to, there we go. We have our acronym list, so that is always important. We end up having our own alphabet soup. You have, I'm sure, one in your own organization, so we have one certainly for here so that we have what I call a shared mental model and we all understand what we are talking about. All right, the objectives today is we're going to describe the cross-setting pressure ulcer injury quality measures. And I know we've taught on this in the past, but there tends to be continued questions, not only in the IRF setting, but in all of the healthcare settings around this. And I think sometimes it's people wanting to kind of accept the answers or the ideas or the suggestions that we've put forward on how to code these. So we keep getting a lot of the same repeat questions, so I'll try to address some of those questions as I go through today. And we hope to be able to have everyone applying the coding instructions accurately and work with the coding scenarios. To that end, I think it's handout 9. You'll have some coding scenarios that we're going to work on, so you just may want to take those out so that you can look at those. So the intent for today is we're going to document the presence or appearance and change in status of pressure ulcer injuries based on a complete and ongoing assessment of the patient's skin guided by clinical standards. It is to promote effective pressure ulcer/injury prevention and skin management program for all patients. And just to level set, what is a pressure ulcer? Well, it's a localized injury to the skin and or underlying tissue. It usually is over a bony prominence. It is as a result of intense and or prolonged pressure. And I think that that's probably one of the most important things that you need to understand. There needs to be pressure involved in the injury for it to be a pressure ulcer. And people forget that. So when they're looking at, maybe something on a mid-calf with no brace or anything like that, and just because it's an open area, they want to stage it as a pressure ulcer. They think everything needs to be staged. So when you're teaching, just a good opportunity there to reinforce that. Or pressure in combination with shear. The pressure ulcer injury can present as intact skin or as an open ulcer, and it may be painful. So changes in skin integrity. So for this measure, an ulcer or an injury/injury is considered new or worsened at discharge if the discharge assessment shows a stage 2 through 4 or unstageable pressure ulcer or injury that was not present on admission at that stage. So this is an important slide. This is the definition for the measures. We'll go through the numerators and denominators next. So the numerator stays in the denominator in which the discharge assessment indicates one or more new or worsened stage 2 through 4 pressure ulcers or unstageable pressure ulcers or injuries as compared to admission. So you have to have an admission, you have to have discharge to compare the two. The denominator then are patient stays with both an admission and a discharge assessment, planned or unplanned, except for those that meet any of the exclusion criteria, and we're going to go through the exclusion criteria. Patients are excluded if the data on new or worsened stage 2, 3, or 4 or unstageable pressure ulcers or injuries including deep tissue injuries, are missing on the discharge assessment. And that makes sense, right? Because I said you have to have the admission and you have to have the discharge assessment. So if you have missing data, we can't calculate it. Makes sense. And the other exclusion is that the patient died during the stay. So they're excluded from this measure. So the measure will be calculated quarterly using a rolling 12 months of data. So that's important if this is part of your job and what you're responsible for. You need to understand it's reported quarterly, and as a new quarter comes on, the oldest quarter falls off. So it's kind of a moving target. For public reporting, the QM scores reported for each quarter is calculated using that 12 months of data. All patients staged during the 12 months, except for those that meet the exclusion criteria, are included in the denominator and are eligible for inclusion in the numerator. For patients with multiple stays during the 12-month time window, each stay is eligible for inclusion in the measure. So if you're into the measures piece of this and trying to understand it, these slides, I think, clearly articulate how do we include, who's excluded, how the measure is rolling, so that we understand what we're looking at. So the risk adjustment, admission assessment items used to adjust this quality measure. So there's a couple of areas that we look at in the assessment that then say someone is either a higher risk or lower risk for a pressure ulcer. So functional mobility admission performance. So the question GG0170C, lying to sitting on side of bed, is a risk adjuster for this measure. Then bowel continence, H0400 bowel continence, so whether they're incontinent or not, is an area that will put you, if they're incontinent, put you at higher risk. Peripheral vascular disease, peripheral arterial disease, or diabetes. So I0900, PVD or PAD, and or I2900, diabetes mellitus. And then the other, or the last risk adjuster is low body mass index based on height and weight. So calculating that using 25A height and 26A weight. So those together then give you your BMI. And we're looking at the low end of the BMI, not the high end of the BMI, for these risk adjusters. So again, those are important when you're looking at the overall picture. So how many, if you're looking at your patient who develops a pressure ulcer, I would also, if I was doing this, go out to these other questions and say, how did we answer these questions? So were they at higher risk for this? Not that that's acceptable to still end up with a pressure ulcer or injury, but it is something that we should look at. So look at the excuse me, first thing in the morning, I've already had my coffee, but got to get my tongue going. Coding guidance and practice coding scenarios. I think the one way to really learn this material is to apply it. So we'll go through lots of opportunities for coding. So CMS is aware of an array of terms used to describe alterations of skin integrity due to pressure, and they include things like pressure ulcer, pressure injury, pressure sore, the old term of a decubitus ulcer, and bed sores. And any number of these words may be used to imply or indicate the same idea. It is acceptable to code pressure-related skin conditions in Section M if different terminology is recorded in the clinical record. So if someone happens to talk about a decubitus ulcer, it equals a pressure ulcer or pressure injury. If the primary cause of the skin alteration is related to pressure, and you will hear that and hear that again, so it's very important, it needs to be related to pressure. When you're considering a wound of mixed etiology, such as moisture-associated skin damage, it is extremely important to identify the primary cause. That's when we start to get into the subtleties of understanding how we're coding this particular area. This is where we have to develop some level of expertise in your staff to understand that they can understand what they are looking at. And I think that's the greatest opportunity that you have in educating your frontline staff. Per the requirements of Section M and the IRF-PAI assessment, pressure should be the primary cause of the wound if you're going to encode it here in this particular section. If the ulcer or injury arises from a combination of factors and pressure is considered the primary cause, then the ulcer or injury would be coded in Section M as a pressure ulcer or injury. Other types of skin injury or alterations are not coded in Section M. So just because they have an open area doesn't mean it absolutely will meet the criteria for pressure. So again, opportunity for education. So there's a variety of different types of pressure ulcers, and CMS adheres to the following guidelines. So a stage 1 pressure injury and DTIs are termed pressure injuries because they are usually a closed wound. A stage 2, 3, or 4 pressure ulcer or unstageable ulcer due to slough or eschar are termed pressure ulcers. So again, slightly different terminology here, so it's important to understand when we're talking about an injury versus an ulcer. And these are termed an ulcer because they are usually an open wound, so the epithelialization is gone from them. An unstageable ulcer or injury due to non-removable dressing devices are termed pressure ulcer injuries because they may be open or closed wounds. So for example, and we're going to go through some of these examples, if we have a non-removable device or dressing and we have a known ulcer or injury related to pressure underneath it, right, known, that's going to be another key piece of that. Since we can't look at it, it may be an ulcer, it may be an injury. We don't know because we can't put our eyes on it at that point in time. So let's look at some of the coding components. So M0300A1 through G1, it identifies the number of unhealed pressure ulcers or injuries at each stage, and it establishes the patient's baseline assessment. So this says closest to admission, I've done a full skin assessment, this is what we have today upon admission. So it sets your admission or your baseline criteria. M0300A1 through G1 identifies the number of unhealed pressure ulcers or injury at each stage. And M0300B2 through G2, these are done at the time of discharge, and it identifies if the unhealed pressure ulcer or injury in M0300B1 through G1 were present on admission, or if the pressure ulcer or injury were acquired or worsened during the stay. And we are going to we're going to do some scenarios around that where we're going to understand. People seem to have a pretty easy time, I think, understanding the admission side of it. It's when we get into the discharge where there's this confusion, like, what am I talking about? Hopefully I'll give you some strategies as we go through that to make this clear and maybe a way to take this back and work with your staff so that they understand how to interpret that discharge question. So when we're going through and we're doing this assessment, we want to use documentation from the previous setting to inform about the original stage of a pressure ulcer or injury. And we want to review the history of each pressure ulcer or injury in the patient's medical record. Why is that important? Well, we should take the opportunity to utilize all of the information that's being communicated to us, both in writing, or maybe you're having a warm handoff, or you have someone who's gone out and done a pre-assessment prior to admitting someone. You want to take all of that information in, especially related to a pressure ulcer, because if someone had an extended stay, let's say you're taking a patient from the acute care side, they may have developed a stage 4 pressure ulcer, and through great care and whatnot, it may be healing, okay? And so when they get admitted to your organization or your IRF, you look at it and you're like, wow, it looks like it's a stage 3 or maybe looking like a stage 2. But in fact, what is that ulcer? It's a stage 4. It's a healing stage 4. So it will stay a stage 4 until it's healed. So that's a really important piece of information to have. So you want to make sure that we have accurate information there. Okay. If the pressure ulcer or injury that is unstageable due to being covered by a non-removable dressing or device, or due to being covered by slough or eschar, is observed on admission to the IRF, subsequently becomes numerically stageable, compare the numeric stage to the numeric stage prior to becoming unstageable, if the documentation is available. So, okay, they came to you and now that wound is covered with slough and eschar. You're unable to stage it, but they had told you it was a stage 3 prior to coming in. The first time that you're able to numerically stage it, you should look at that and say it was previously classified at a higher numerical stage or whatever. You can say it is now a stage 3. And it should be continued to be classified at the higher numeric stage. So again, if it was that, let's go back to that example, it was a stage 4. It's starting to heal. Now it gets covered with slough. They come to you. Now, once you're able to clean all that slough up, you debride the wound, and now it's a stage 3, okay? It appears to you to be a stage 3. It will still be a stage 4, right? Because you have clear documentation from the previous setting. So you'll see how important that is. So determine the deepest anatomical stage, identify unstageable pressure ulcers or injury, and this is for section M0300A through G. So think about in your facilities who is coding this information, who is doing the assessments, and make sure that you feel comfortable and that these staff members are competent to be able to do that. For the discharge assessment, determine the number of pressure ulcers or injury that were present upon admission. For detailed instructions, refer to section M in the Inpatient Rehabilitation Facility Patient Assessment Instrument Manual. So there's, again, lots of examples in there, and we're going to go through some ones here. So when we're doing the discharge assessment, one, you first identify the pressure ulcers or injury present upon the discharge assessment. So think about it as like 2 stages. So the first thing is saying, okay, I'm getting ready for discharge. I'm doing the discharge assessment. This is a point in time. What does my patient look like today? What do we have related to on discharge pressure ulcers or injuries? Encode them. Some might have completely healed. Okay, so what do I have on discharge? You want to code that. And then you want to determine the number of those identified at that same stage that were present upon admission. So it's a 2-phase kind of question. So I find that when I teach this with staff, that they find that easier. Like, so it's, I said, first thing, it's a point in time, what do I have on discharge? Then, whatever I then say, go down my list that I have, how many of those were present upon admission at the same stage? So that's how you get through that question. That's a good way of kind of breaking it out for staff. So we have an example here of a patient is admitted to the IRF with a healed pressure ulcer or injury, and a pressure ulcer or injury occurs in the same anatomical area and remains at discharge. It would be coded as observed at discharge. It would not be coded as present on admission on the discharge assessment. Therefore, the pressure ulcer injury would be considered new or facility acquired. So if in this situation, if the injury, the pressure ulcer, so it's healed, right, it comes into you, you know that they had a healed, let's say stage 4 on the trochanter, and then it occurs at the same area and remains at discharge, it would be coded as observed at discharge, and would not be coded, as present upon admission. So, but it is important to understand where someone has had a pressure ulcer in the past, and why is that? Anyone know? Because the skin's not as strong, right? The tensile strength of the skin and the underlying structures are not as strong. It's about 80%. So someone's at higher risk. So from a care planning and prevention, you want to make sure that we're paying attention to those areas of special attention because they have a higher risk of breaking down. So here's just a screenshot looking at on admission, the current number of unhealed pressure ulcers or injuries, and we are going to go through each one of these questions and through our examples. So M0300A1 through G1, for the coding instructions here, we're going to complete this upon admission and at discharge. We enter the number of pressure ulcers or injuries that are currently present. And we enter 0 if no pressure or ulcer or injury are present at that stage. So we answer each one of these questions and we say, yes, they have it. If they have it, how many do they have at that particular stage? Then we look at discharge, and again, this is a screenshot from discharge, so you can look at that. We're actually going to go through with some examples, and you are going to use your tool. But the first part of this question says, how many of these pressure ulcers do we have? For example, the number of stage 2 pressure ulcers. I'm looking at that particular question. And if you had 0, and this is at discharge, how many do I have today? Do I have 0? Do I have 1? Do I have 2? Whatever it is, you put that number. And then it says, now, of that number, because you just told me you had 1. Of that 1 that you have at discharge, how many of these ones of these stage 2 pressure ulcers were present upon admission? So that's that two-pronged question that we're asking. So that's an important thing. So how many do I have today? So I have a stage 2 pressure ulcer here, okay? So we're saying I have a stage 2 pressure ulcer, and that's at discharge. And then the next question I'm asking, of those stage 2 pressure ulcers, how many of those were present upon admission? Well, I didn't have any, okay? So there was 0 that were present upon admission. And that tells me that it wasn't there on admission. I had it during the stay and at discharge, so it was acquired basically in the inpatient rehab facility. And then this continues again. These are the screenshots looking at unstageable for slough and eschar, and then unstageable deep tissue injury. So when we get into M0300B2 through G2, we want to enter the number of these pressure ulcers or injuries that were present upon admission. And you can see instructions under steps for completing M0300A through G. Step number 3, determine present on upon admission in the manual, and enter 0 if no pressure ulcers or injury were noted at the time of admission. And again, we're going to go through lots of examples on this. Present upon admission are coded at discharge and will address whether the pressure ulcer or injury were observed at discharge. So 1, again, was it present upon admission, or was it acquired or worsened during stay? A pressure ulcer or injury reported at discharge or coded as not present on admission on the discharge assessment would be interpreted as new or worsened, which I just gave you an example of. So if it wasn't there and now it's there, it was considered new or worsened. A pressure ulcer or injury reported at discharge and coded as present on admission on the discharge assessment at the same stage would not be considered new or worsened. So if I had a stage 3 on my right hip and I went through my stay and I still have that stage 3 on my right hip, it's not covered in slough or eschar, and I can code it, it's considered that it was there on admission, and so it is not considered to be new or worsened. So this whole idea of program interruption, which is something that you deal with in the IRF setting, if a patient is transferred from the inpatient rehab facility or the IRF to an acute care hospital and returns within 3 days, including the day of transfer, the transfer is considered a program interruption and is not considered a new admission. I'm not telling you anything that you don't already know, but this is important related to coding for pressure ulcers. Therefore, any new pressure ulcer or injury formation or increase in numerical staging that occurs during the program interruption should not be coded as present upon admission. So if you send someone out, let's talk about the right hip, so you send someone out with a stage 2 to the acute care setting, they come back within the 3 days, including that day of transfer, and now they have a stage 3 in that. That is not considered present upon admission. It's considered, worsened, all right, on discharge. If they still have that stage, it will be a stage 3 if it hasn't completely healed. You want to make sure that you're not saying, oh, just because I had that program interruption and it worsened while in the hospital, you get to still own it, which is, but just so that's an important piece. So let's look at some practice scenarios, because I think that's the best way to apply the methodology that we're looking at. So in this practice scenario, this will be a Slido, so if you can get your phones out, these will be important. So a patient is admitted to the IRF with a stage 2 pressure ulcer on the left hip. The patient is transported to the acute care hospital and returns to the IRF within 2 days. Upon return to the IRF setting, the left hip pressure ulcer is full thickness ulcer, assessed to be a stage 3. This is how well, I guess I didn't realize that this was exactly the scenario that we were going to be doing at this point. The patient is discharged to home with a stage 3 pressure ulcer. All right, so let's look at the question here. So using Slido, how would you code M0300 on the admission assessment? Would it be a stage 2? A stage 3, a stage 4, or unstageable deep tissue injury? Okay, we're just getting a few more answers in here. Just give it a minute. Okay, so let's see, we've got most people answering in. And so how would we code this? On admission, it would be coded as a stage 2, right? Because they came into you, it was a stage 2. Next question is, how would you code M0300 on the discharge assessment? So again, this is Slido. I'll give you a moment to start answering this. Just give it, numbers are still coming in, looks good. All right, looks like we're not having a lot of variability, so let's look at the answer. How would you code M0300 on discharge? It would be a stage 3, right? They had the stage 2 on admission, they had an interrupted stay, it progressed to a 3, they came back to you, it's not considered new, not considered on admission. At discharge, they have a stage 3, and then it would ask you, of those stage 3, how many of those were present upon admission? And you would say 0. Okay. Now I gave you the answer to this question. This is how bad when I do these. Number of these stage 3 pressure ulcers that were present upon admission. Okay, good. I gave that away. So let's look at the answer. So we would say how many of these were present upon admission? 0. That's where people trip up. That's the question answer issue in this particular coding area of this assessment. All right, so if you were looking at your assessment tool, we would say the number of stage 2 pressure ulcers upon admission, we had 1. And on discharge, so on admission we can, and sometimes I find this even easier, you know, when you start filling this out, you do on admission, so this is your discharge assessment, but you have that column, what did I have on admission? Go ahead and just go down the line, fill in all your admission information. And then on discharge, then we're now saying, what do they have today? For this particular patient, we asked the discharge assessment, did they have any stage 2s? No. So the next question says, of those stage 2, how many were present upon admission? Because we don't have any, if you put a 0 in there, it's automatically a skip for the next box. If this is in your computerized system, they usually put skip patterns in, it just skips you out to the next question. The next question says, the number 3 pressure ulcers, we didn't have any upon admission, we have 1 on discharge. We then have to answer the question, because we have at least 1 in that answer on discharge, how many of those were present upon admission? And we say 0. So this goes through the rationale, we talked about that. They had that stage 2 on the left hip. We coded it as a 1. Then the patient transferred, developed, returned in those 2 days. There was no new admission assessment that required a change in the pressure ulcer status, so it's captured on the discharge assessment. And so that's how we had our coding here. So it's now, the stage 3 was not a present upon admission. So let's look at another scenario here. I'm sorry, unstageable pressure ulcers. So let's talk about unstageable pressure ulcers. So visual inspection of the wound bed is necessary for accurate staging, right? If we can't see the wound bed, then it's going to be really hard for us to stage that. So pressure ulcers that have eschar or slough tissue present, such as the anatomical depth of soft tissue damage, cannot be visualized or inspected or palpated. The wound bed should be classified as unstageable. If you can't clearly understand what you're looking at, then it's unstageable. If the wound bed is only partially covered by eschar or slough, and to the extent of the soft tissue damage can be visualized and inspected or palpated, the ulcer should be numerically staged and should not be coded as unstageable. So for example, if you have a stage 4, that's a very common one, and you look and you see tendon or bone, even if it's partially covered, you know it's a stage 4. So you wouldn't then cover that, say that's unstageable. You would say that that's a stage 4. So let's look at another coding scenario. So a patient is admitted to the IRF with a stage 4 pressure ulcer on the left hip. When the pressure ulcer is reassessed at discharge, it is entirely covered with eschar, and the wound bed cannot be assessed. The patient is discharged with an unstageable pressure ulcer due to slough or eschar. So it's a little bit of a different scenario here. And these scenarios should be on your coding, so let's go through. How would you code M0300 on the admission assessment? Would it be a stage 3, being a 1, a stage 4 is a 1, unstageable due to slough or eschar, or unstageable due to a deep tissue injury? Okay. Let's look at this now. See what the answer is. How would you code M0300 on the admission assessment? Let's see the answer. It would be a stage 4. And let's look at the, and then how would you code the M0300 on the discharge assessment? Okay. All right, great. Let's look at the answer. And so how would we code it? And would it be a stage 3, a stage 4, unstageable, or unstageable DTI? And we would be coding that as unstageable slough or eschar. So everyone did very well on that. So the next question is, was this unstageable pressure ulcer due to slough or eschar present upon admission? Is it yes, no, or skip? Okay. Got a little bit of dissent here. A couple people think yes, most think no. Let's look at the answer. So the answer is no. And we're going to go through. So, all right, let's look at the coding here, if we were actually encoding this. So we would have no stage 2 pressure ulcers at admission or discharge, no stage 3 at admission or discharge. We had 1 stage 4 upon admission and none at discharge. And then we have no unstageable due to non-removable dressings. And then we have number of unstageable pressure ulcers due to coverage of the wound bed by slough or eschar. We didn't have any of that at admission, but we do have 1 at discharge. And then number of these unstageable pressure ulcers due to slough or eschar that were present upon admission. So we only have 1, and it wasn't there on admission, so we put a 0 in there. So what's the rationale here? So at admission, the patient had a stage 4 pressure ulcer on the left hip, so M0300D1 is coded as a 1. And then the stage 4 pressure ulcer on the left hip developed eschar and is unable to be assessed and numerically staged on discharge. And the patient is discharged with an unstageable pressure ulcer due to slough or eschar. So here we have M0300D1 is coded as the 0, and M0300F1 is coded as 1. And M300F2, those were how many were present upon admission, is coded at a 0 on the discharge assessment. So now let's talk about non-removable dressings or devices. So a non-removable dressing or device refers to a dressing or device that may not be removed from the patient per a physician's order. So a non-removable dressing or device includes, for example, a primary surgical dressing that cannot be removed, or an orthopedic device or a cast, so something that you specifically have an order that says, you can't remove it. So another key caveat for here, and this again is an area where people struggle a little bit, and we get lots of questions, that we have to have a known pressure ulcer or injury covered by that non-removable dressing or device should be coded as unstageable. So the pressure ulcer injuries are considered unstageable due to the inability to further assess and document the pressure ulcer injury that is covered by that non-removable dressing or device. But I can't stress enough, you have to know that it's there. And you have to know that it's pressure related for you to code this item. So it is going to be critically important that you get this information from a previous setting, or if someone develops one in your organization, that's fine, and then they end up with some sort of a removable device or cast or something over that. So now you know that it was there, and now until that device comes off, you can't assess it. Then you would code that. But you have to know that something's under there. That's a key caveat that some people get miss. So known refers to when there's documentation and available indicating that a pressure ulcer injury exists under the non-removable dressing. You want to review the medical record for documentation of that pressure ulcer or injury covered by that dressing. Do not assume that there is a pressure ulcer or injury that is covered by a non-removable dressing or device without actually knowing there's something under there. So let's look at another coding scenario. So a patient's admitted to your IRF with documentation in the medical record of a sacral pressure ulcer injury, and the ulcer injury is covered by a non-removable dressing. Therefore, the pressure ulcer injury is unstageable. On day 4 of the IRF stay, the dressing is removed by the physician and assessed to reveal stage 3 pressure ulcer. On day 9 of the IRF stay, the pressure ulcer is covered with eschar and is assessed as unstageable. The eschar covers the ulcer, is unchanged at the time of discharge. So they come in to you, they have a sacral ulcer. It's covered with a device that you can't, either a dressing or device, you can't stage it, but you know that it's there. And then at day 4, we know that we can remove it. We have a stage 3. By day 9, and at discharge, it's covered with eschar. All right. So using Slido, how would you code on admission assessment? So would you code M0300CA as stage 3, unstageable, non-removable dressing, unstageable due to slough or eschar, or unstageable deep tissue injury? Okay. Getting most people weighing in here, so let's look at the answer. And the answer is B, which most people got. We are on admission unstageable due to non-removable dressing or device because we know that there's something underneath there and we can't remove it. How would you code M0300 on discharge assessment? So again, this is discharge. Would it be a stage 3? An unstageable due to a non-removable dressing, unstageable due to slough or eschar, or unstageable? And let's look at the answer. We got most people clicking in. And here we would code this as unstageable due to slough or eschar. So we knew it was a stage 3, but now it's covered in slough or eschar. Was this unstageable pressure ulcer due to slough or eschar present upon admission? Yes or no, or skip? Okay, let's look at the answer. And the answer is no, and most people got that correct. So, and then if we were coding this, again, you could just see how we would do the zeros here and skip. And then we would say they had an unstageable due to non-removable dressing. We'd code that as a 1. And then on the discharge, M0300F1, we now have that unstageable due to slough or eschar. And we code the next 300F2 as a 0 because that 1 was not present upon admission. So here's the rationale, and we just talked about it. So we knew about it. They had the known ulcer, so we coded that as a 1 on the admission assessment for non-removable dressing. Okay. And then this goes on to talk about the unstageable due to slough or eschar. All right. Got a lot to cover here, so we're just going to move on. So in this scenario, a patient is admitted to the IRF with a stage 3 pressure ulcer on the coccyx. On day 5 of her IRF stay, the ulcer is assessed as a stage 4. She is seen at the wound clinic and returns to the IRF with a dressing and orders that the dressing is to remain intact until the next clinical visit. The patient is discharged to a skilled nursing facility prior to the follow-up to the wound clinic visit. At the time of discharge, the ulcer is covered with a non-removable dressing. So this is not an uncommon situation. So let's look at this. How would you code M0300 on admission assessment? Would you code a stage 3, a stage 4, unstageable non-removable dressing, or slough or eschar? Again, this is an admission. Okay, we have most people answering in, so let's look at the answer. And here we would code a stage 3, right? They came in with a stage 3 pressure ulcer or injury. So how would you code M0300 on discharge assessment? Would it be a stage 3, a stage 4, or unstageable non-removable dressing, or unstageable slough or eschar? We have most people answering in, so let's look at the answer. And so here we have the answer would be unstageable due to a non-removable dressing. So we know that that was present when they were discharged. Was this unstageable pressure ulcer injury due to a non-removable dressing or device present upon admission? And the answer is either yes or no, or skip. And we'll look at the answer. And the answer is no, because it wasn't present upon admission. So if we were going to code this, we just want to give you a scenario what this would look like. So we have our coding here, and then we get into our areas with non-removable dressing. So they had an unstageable due to a non-removable dressing, 0, but they had 1 at discharge. So you'll see the coding here. All right, and this gives us our rationale. So we have, at admission, the patient has a stage 3 pressure ulcer. We coded that as 1, and then it goes through on the discharge assessment, and we've talked about that. So let's talk about healed pressure ulcers or injury. So the terminology referring to healed versus unhealed ulcers and injuries refers to whether the ulcer injury is closed versus open. Because we know that wounds heal from the inside out so it's hard to say whether it's truly healed, but for our terms is whether it's closed or not. So a stage 1 pressure injury, deep tissue injury, and unstageable pressure ulcer, although covered with tissue, eschar, or slough, would not be considered healed. So this is just a subtlety, so we want to make sure that people say, oh, well, they have a stage 1, and you told me if the skin is intact, then that's healed. Well, we know that a stage 1 is that persistent redness, and so in that situation, it wouldn't be healed. Remember, we never reverse stage, and that's probably one of the hardest things for people to know because it's what they see and they want to code it as that. That's really important when someone comes to you and you know that a wound an ulcer was a stage 4, and now it might be looking like a stage 2 to you. It still is a stage 4. It's just a healing stage 4. So in this coding scenario, a patient is admitted to the IRF with multiple fractures following a motor vehicle accident, and the skin assessment upon admission reveals no pressure ulcers or injuries. On day 7 of the IRF stay, a stage 2 pressure ulcer is identified on the coccyx. Wound treatment is initiated, and the pressure ulcer successfully heals a week prior to discharge. At discharge, the patient's skin assessment reveals a healed stage 2 pressure ulcer on the coccyx. So how would you code M0210 on the admission assessment? Does this patient have 1 or more unhealed pressure ulcers or injury? So let's go to the answers. Let's see what we said here. So do they have 1 or more unhealed pressure ulcers? And our answer is no. So in this situation, we're done with the skin section, right? And we'd skip right out to N2001, starting the drug regimen review. Because we're saying their skin is intact. So we're done with that. But how would you code M0210 on the discharge assessment? Does the patient have 1 or more unhealed pressure ulcers or injuries? A lot of people answering in on this. We have a mixed kind of bag here. Okay, let's look at the answer. And the answer is no, and we would again skip to N2005 medication interventions. Why? Because they came in, their skin was intact, they developed the stage 2, you healed the stage 2, and on discharge, the skin is intact. So these are really snapshots in time, admission, discharge. Even though they had a wound in between, we don't capture that wound for this assessment. You certainly would capture it clinically. You would certainly treat it. Obviously, they did here, but it wouldn't be captured on the assessment. So basically what I said, they had the ulcer. They came in intact. They developed the ulcer. You healed the ulcer. So both would be coded as no. So let's look at medical device-related pressure injuries. When an ulcer injury is caused due to the use of a medical device, Assess the area to determine if the pressure is the primary cause. Again, that's going back to that same language. Is it the primary cause? And these ulcers or injury generally conform to the pattern or shape of the device. And I think most of us, if you've been clinical, you've seen one of these. If the pressure is determined to be the primary cause, use the staging system to stage the ulcer and code in section M of the IRF-PAI. If the ulcer injury is not due to pressure, do not code in section M. So often you'll see people kind of being detectives. They're putting a splint back on or seating them in a particular wheelchair and trying to look, all right, here's my area or injury. Does it line up with anything to determine whether pressure was involved? So here we have a scenario. A patient is admitted to the IRF with a right ankle foot orthosis to compensate for weakness with a foot drop. On the initial skin assessment, the clinician notes a stage 2 pressure ulcer on the right calf that conforms to the shape of the AFO. The orthotist, I can never say this word, and I say it every time. The orthotist is consulted and the AFO is adjusted. At discharge, the ulcer has decreased in dimensions and remains an open stage 2 pressure ulcer. No other pressure ulcers or injuries are noted. So they identified it, they brought in someone to work on it. So here, let's look at the coding scenario here. So let's just walk through this. Here we have the number of stage 1 pressure ulcers or injuries on admission. What would you say? Right. How about on discharge? Right. And so the next question we would, okay, the number of stage 2 pressure ulcers or injuries, we had 1. On discharge, right, we had 1. Number of the stage 2 pressure ulcers that were present upon admission, right. How about stage 3s on admission, on discharge, right. And then we would skip. And then how about stage 4s on discharge, and then we would skip. Okay. How about number of unstageable pressure ulcers due to non-removable dressings? 0. Discharge assessments? Okay. And then number of these unstageable pressure ulcers or injuries due to non-removable dressings or devices? Right? I'd skip it, remember? How about number of pressure ulcers due to slough or eschar? Okay. How about a discharge assessment? Right. And the next one would be skip, right. And then how about number of unstageable pressure ulcers or injuries with deep tissue? Right. And then discharge assessment? 0. And then the next one is a skip, right. Okay. So here's the rationale. The area was identified on the calf due to the AFO and was determined to be caused by pressure of the device against the skin. And then the medical device-related pressure injuries resulted from the use of the device designed and applied for diagnostic and therapeutic purpose. The resultant pressure injury generally conforms to the pattern or shape of the device and the injury to be staged using the staging system. And just note that the National Pressure Ulcer Advisory Panel resources and education and clinical resources is an area where you can go out and get some additional information. And just know that our coding for CMS is adapted from that area. All right. So we have some more practice scenarios here. Why don't you take out your coding sheets? I'm going to go to the next scenario here. Okay. So if you take out your coding sheets, does everyone have that? So let's find practice scenario 7. And then I think there's practice scenario 8. I'll just go through this here. Okay. Why don't we just take a couple of minutes for you that are online, take out the coding scenarios, and why don't you go through these 2 coding scenarios, encode it on your paper, and then what we're going to do is pull the group back in just a couple of minutes, and then we will go through the scenarios and debrief on them. So it gives you an opportunity to now use your own brains to work through these and think about the rationale that you would use if you're explaining this to your staff. Okay, it looks like most people are done. Hopefully, those of you watching live streaming are done also. But let's just take the opportunity because we're going to go through all of these two scenarios, and then I have some ending slides, and then we'll be closing out the session. So let's look at this practice coding scenario 7. Take out your coding sheets. So upon admission to the IRF, the patient's skin assessment reveals 2 stage 4 pressure ulcers. One is located on the coccyx and the other is on the right hip, so 2 stage 4s. At discharge, the patient's skin assessment reveals a healed stage 4 pressure ulcer on the right hip. Yay to the care that was provided. The pressure ulcer on the coccyx remains a stage 4 with granulating tissue visible in 50% of the wound bed, and no slough or eschar is noted. So in taking this scenario, let's look at our coding. So let's imagine this, you have your coding sheets in front of you, so let's just follow along and then you can make any corrections, and then we'll talk about the rationale. So the number of stage 1 pressure ulcers on admission, how many did we have? Did we have any? We had none, okay. How about on the discharge assessment, did we have any stage 1 pressure ulcers? No. And so the next question is number of stage 2 pressure ulcers. Did we have any on admission assessment? No. Did we have any on the discharge assessment? No. And so then that next question would automatically be a skip because we had a 0, right? Because it always asks of the number that was present at discharge, how many were at present upon admission. Number of stage 3 pressure ulcers upon admission? We didn't have any. How about the number on discharge? No, we didn't have any on discharge. And then again, the next one would be a skip. Number of stage 4 pressure ulcers on admission? They had 2, right? And then the number of stage 4 on the discharge assessment? Okay, coded 1, right. And we coded 1 because 1 healed, right? Okay. And the number of these stage 4 pressure ulcers that were present upon admission, because we're saying there's 1 on discharge, how many of those were present upon admission? 1. So really what it's, again, this question is just referring back. It's saying, of the ones I have at discharge, I have 1 at discharge, right? Left, because you healed 1. So I have 1 left. Of that 1, because that's the question it's asking you, how many of that 1 were present upon admission? So it was 1. Even though they had 2, 1 of them, which is what you still have, was present upon admission. That's just telling the system that, yes, they still have 1, but they had that on admission also. Okay. Then we look through and we said the number of unstageable pressure ulcers or injuries due to non-removable dressings. Do we have any of those on admission? No. Do we have any on discharge? No. So then we skip. And then same thing. The rest of these are no. We didn't have any ulcers due to slough or eschar on admission or discharge, and we didn't have any unstageable pressure injuries or deep tissue injuries. So this would be the rest of that coding. So the rationale, and again, this is important, you'll have all of these completed with the answers to use in training materials, and or I would encourage you to take your own cases in your facilities and go through a similar exercise. But upon admission, the patient had 2 stage 4 pressure ulcers, 1 on the coccyx and 1 on the right hip. So M0300D1 was coded as 2 on the admission assessment. Then at discharge, the stage 4 pressure ulcer on the right hip was healed. And would not be captured in M0300, right, because it's not there on discharge. The coccyx pressure ulcer remains as a stage 4, therefore on discharge assessment, we would code M0300D1 as a 1, and then when we ask how many of those were present on admission, we would say in M0300D2 that we had 1 of those present upon admission. So that's the rationale that we could use. All right, so we then had another scenario that you worked on, which is practice scenario 8. So on admission to the IRF, the patient's skin assessment reveals 3 small, distinct stage 2 pressure ulcers in the sacral area. Upon discharge assessment, 2 of the sacral pressure ulcers have merged and remain a stage 2. The 3rd sacral pressure ulcer has increased to a stage 3. So let's go through this practice scenario. Let's see how people did. So number of stage 1 pressure ulcers on admission? 0. Good. How many at discharge? 0. How many stage 2 pressure ulcers on admission? We had 3, right? 3 distinct pressure ulcers. How many on the discharge assessment? Any guess? 1, right. We have 1. How many of these stage 2 pressure ulcers that were present upon admission? 2, 1, I'm hearing a couple of different numbers. Remember, it's 1 because we're talking about what we have left at discharge. It's only referring back to that discharge. You have 1 ulcer left, so you can't say 2 of the 1 ulcers. Do you see what I mean? That how many were present upon admission is referring back to that, it ties back to that I have 1 present. Even though I had 2 on admission, it's saying how many do I have at discharge? Of those that are present upon at discharge, that's how the verbiage is. Of those that are present upon discharge, how many of that 1, 2, 6, whatever the number is, were present upon admission? So you only have 1, the max number you can do there is 1. How many stage 3 pressure ulcers? Okay, on admission, I'm sorry, I didn't finish the verbiage here. On admission, how many stage 3s? 0. How many on discharge? 1, right. How many of the stage 3 pressure ulcers were present upon admission? 0, right, because they were all stage 2s when they came in. How many of stage 4 pressure ulcers? On admission? 0. How about at discharge? 0. And so the next one would be skip, right? And then number of unstageable pressure ulcers or injury due to non-removable dressing. Okay, we would have 0, 0. The rest of these are all 0s because we didn't have slough, eschar, or any of the non-removable dressings. All right, so it's important, let's go through the rationale for this particular coding scenario. So upon admission, the patient had 3 stage 2 pressure ulcers in the sacral area. So you were correct, M0 300B1 is coded as 3 on the admission assessment. At discharge, 2 of the sacral pressure ulcers have merged and remain a stage 2. The 3rd sacral pressure ulcer has increased to a stage 3. So on discharge assessment, when the 2 pressure ulcers, they must have been right near each other, the 2 stage 2 pressure ulcers, and sometimes they have this little bit of a skin bridge, and when that bridge goes away, they just become one ulcer, okay? It's at the same stage there. So M0 300B1 is coded as a 1, M0 300B1 is coded as a 1, M0 300C1 is coded as a 1, and M300C2 is coded as a 0. All right, so this is basically what I just said. If 2 or more pressure ulcers or injuries were observed at the same time of admission and merge into a single pressure ulcer or injury by discharge, the resulting pressure ulcer or injury is reported as 1 single pressure ulcer or injury at the appropriate stage on the IRF-PAI. I'm now competing with vibrations in the ceiling here. Hopefully you can hear me if you're listening remotely. So that's, again, an important concept if you're having your general staff nurses who are assessing and then coding, that they understand about that skin bridge and when that skin bridge goes away and they merge. And that's not an uncommon thing that can happen in that sacral kind of area, that goes away. They're very small, and then they open up, that bridge goes away, and it stays as a stage 2 in this particular situation, but they become 1. So let's look at finishing up and talking about some other unique ulcers. Hopefully, first off, that going through these scenarios, the best way to educate and teach and for staff to learn about these are these various scenarios. And I love the fact we have a lot of scenarios in here and in the manual, but taking your own situation, taking your own patients, and writing up scenarios around them and the rationale can give you an opportunity to train and educate your staff. But mucosal ulcers. So mucosal pressure ulcers are not staged using the skin pressure ulcer injury staging system because the anatomical tissue comparisons cannot be made. So this is an important concept, again, to make sure that your staff understand. Therefore, mucosal ulcers, for example, those related to NG tubes, oxygen tubing, endotracheal tubes, urinary catheter, mucosal ulcers in the oral cavity should not be coded on the IRF-PAI. So again, this is, I've looked at many assessments, and this can be a common issue where staff want to treat all ulcers, they want to stage them. Actually, in fact, they want to stage every wound, whether it's pressure related or not. So we have to educate them. Has to have pressure as a primary source. Then we have to have them understand that there are openings that are caused by other things than ulcers, like stasis ulcers and whatnot. And then the third thing is they need to understand around the mucosal ulcers. So you have lots to make sure that if you're going back into your own organization, would you be confident that if you went up to any staff who were responsible for this, would they understand these subtleties? If not, opportunity for education. Just a really great thing. So I would put that down in your action plan as just going back. So let me do some gut checking. If I'm unsure, let me just validate. Take some of your best, what you consider your best, high performers, ask them some of these questions, and then take kind of your general staff who maybe haven't had as much passion or, in doing this and really are invested, that they may have an opportunity to make sure that they understand these subtleties. So we want to have accurate assessment. Of course, you want to have the same thing. We want to then encode the IRF-PAI with accurate information, so that these, again, are impacting kind of public reporting quality measures. So let's talk about this idea of a Kennedy ulcer. So it's a skin ulcer that occurs at the end of life and are known as Kennedy or terminal ulcers. Most of us, if you've been around your career and any length of time, you've seen these. And a Kennedy or terminal skin ulcers are not captured in Section M. The evolution and appearance differ from a typical pressure ulcer or injury, and it's related to tissue perfusion issues due to organ and skin failure. As we know, our skin is one of our largest organs, and so it's a totally different process. That does not mean you ignore them clinically. That's not what we're saying here. We still want you to go ahead, treat them, do all the things you need to do. We just don't want you to encode them into the IRF-PAI. So again, another opportunity to educate your staff. So for the etiology, if you don't know a lot about these ulcers, that's maybe an opportunity to do an education with your staff. The evolution and appearance differs from the typical pressure ulcer injury. They generally appear from 6 weeks to 2 to 3 days before death, and they present as a pear-shaped purple area with irregular borders, usually on kind of that coccyx type of area. But there's lots of great materials out there. If you Google some of this, there's some great pictures that you can use for education and training. Or if you actually have a patient who has an ulcer like this, and a newer nurse has not seen it, it is an opportunity to educate. Bring them in and let them take a look, as long as it's okay with the patient. It's a great thing to be able to see it yourself. You'll usually never forget what you've seen. So our summary, changes in skin integrity post-acute care. The pressure ulcer injury is a cross-setting quality measure. So we are looking at this in all of the PAC settings, they're being asked to do the same thing that you're being asked to do. Data collection for this measure began on October 1st, 2018, so this is something you've been doing for a while, yet we are getting lots of questions continually about this. And I think some of this is getting back there, all those kind of key points that I talked about, which are education points, the kind of the subtleties using this. Using data elements that already exist in the IRF-PAI, and this measure replaces the percent of residents or patients with pressure ulcers that are new or worsened, because we added and changed some of the assessment items. So for this measure, an ulcer injury is considered new or worsened at discharge if the discharge assessment shows a stage 2 through 4 or unstageable pressure ulcer or injury that was not present on admission at that stage. I'm sure you are sick of me saying that, but that is the key point behind this. Please submit your questions, and we will try to answer them and give clarity. Take out your action plans. I think this is an opportunity for you to say, oh, let me just go back and do this. Now, I always think I'm going to remember all this when I leave a conference. I don't, so just take the notes, and then you can flesh out those ideas once you get back to your organizations. And I am done. And I will hand this back over to Bridget.